Latin America with the Pan American Association of Infectious Diseases, as well with other associations, on the importance precisely of the evidence-based and also in general clinical practice guidelines, which all of them are really important and has been discussed precisely for the matter to orienting the decision-making precisely. So these clinical practice guidelines are important documents for incorporating scientific evidence into healthcare decision-making recommendation, which in the case of clinical care is particularly important. And when panels develop these guidelines, these create trustworthy in this guideline are of high quality and can evaluate, in addition, these different aspects of intervention, contextual aspects such as the use of resource, values, and preference of the patient. Just to go very quickly on this, during the COVID pandemic, this has been an overwhelming example in multiple countries. This is in the United States, the guidelines of the Infectious Disease Society of America. But early in the pandemic, and we are very proud of this, in March 2020, starting the pandemic, and we have our first case in Colombia on March 6, 2020, we developed the Colombian evidence-based clinical guidelines that in fact were updated and were key for the management of this emerging condition. And this year, precisely also in the case of the region with the Pan American Association of Infectious Diseases, also key questions related to the management of the disease has been following the methods such as GRADE, which is important for the development of these evidence-based guidelines for different aspects related to the management and also specifically for the therapy based precisely on the approach. As you will see, these are the characteristics, forest plot, assessing the evidence, assessing the studies and the clinical trials that support the different therapeutic approach. So in the specific case of rabies, evidence-based guidelines are crucial also for rabies management as they provide a structure and scientifically validated approach to treating and preventing this deadly viral disease. And right now it's obviously well known for most of here that we have this kind of recommendation, such as very important in the United States, for example, the Advisory Committee on Immunization Practice, and this is well known in other cited publications for the case of these from the CDC, the Morbidity and Mortality Weekly Report. Obviously, with this information about available rabies biologics, for example, in the United States, aspects such as the post-exposure prophylaxis in the country, as well also about pre-exposure prophylaxis guide. Here in Colombia, and it was in part was presented yesterday. We have these guidelines also for the clinical integral approach for rabies exposure and rabies in general, discussing all the aspects related to the risk according to exposure, to the clinical presentation. And obviously in many other countries, such as, for example, very quickly here in United Kingdom or in other countries in Latin America, such as the case of Peru, and we were discussing here yesterday with our friend Sergio Recuenco from Peru, not only the implications of all what is happening with this, but currently the case that actually has been conferred, for example, in a 50-year-old female in Arequipa in Peru, which has been associated in part with the problems of not having the appropriate adherence to the guidelines, as well educations and many other aspects that are important for Latin American regarding this. But also at the same time, I think it's important that there are many sites related to the evidence-based medicine that right now are considered important of this also for the context of rabies, such as Medscape, UpToDate, and other sites that manage evidence-based information, which is important for the clinician in terms of having a quick approach for the different components and aspects of the management of rabies. And I would like to go in close in my last 5 minutes, also approaching to this. Why is the reason I propose this discussion, and what is this in the context of the development of evidence-based guidelines, specifically for the context of rabies? Well, the first is important for the standardization of care. Evidence-based guidelines establish a standardized framework for diagnosing, treating, and preventing rabies. This consistency ensures that health professionals follow the most effective and up-to-date practices leading to better patient outcomes. And we have to remember that the evidence-based guidelines are once developed, update periodical, and this is also important for update evidence-based information. Improve patient care as following evidence-based guidelines. Healthcare providers may inform decisions about rabies management. This in turn results in more effective treatment and care for individuals who might have been exposed to the virus. Safety, which is also important. Rabies and transmission and in the evidence-based guideline healthcare providers to take appropriate precautions and manage with patients with potential rabies exposure, as is well known. The importance also, especially in resource-constrained settings, to address the cost-effectiveness of the intervention, which is important. Even the evidence-based guidelines are cost-effective. This is also an important aspect related to this. Research and innovation, and these are rooted in ongoing research and scientific evidence. The public health impact as effective rabies management as guided by the evidence-based practice can have a significant impact on public health, including time interventions and vaccination programs, among other things. And another important thing is the global consistencies related to what is happening to this in different geographic settings regarding to the availability of guidelines that are not always in all the settings available. Just for the conclusions in my last 3 minutes, this is important at the same time that we need from the scientific society to call on and rise on the awareness and importance of continuing doing this, and to remember that although it has decreased, rabies is still an important condition that need to be addressed to target appropriately the elimination. And in fact, from our society, the Latin American Society for Travel Medicine, this is also important because this is a risk not only for people living in areas with transmission of rabies, but people arriving to there. And as you will see from the CDC, obviously this advises to travelers for different kinds of risks according to the places and the epidemiological conditions is important. Right now that on September 28 was the global days again the rabies, we also use this kind of campaigns from our society to call on this, specifically also in the context of travelers, as in travelers, one of the key aspects is prevention. And in travel medicine, we have the 3 R's, the routine, the require, and the recommended immunization. Obviously, that in this case, these include rabies. And as you will see, obviously, in the assessment of this, rabies is right now a condition of low incidence comparatively to other more frequent conditions in traveler. But again, the impact of this, the second dimension, is high, important considering also, for example, the case fatality rate, which is high. So we recommend to consult the different sources of information for this, including, for example, in some of our main guidelines for travel medicine, what is happening regarding different aspects, for example, of prevention or management of rabies, as is, for example, the case of the Yellow Book 2024 that has been published. A final message in my last minute. It's important that these guidelines play a vital role in improving rabies management with adherence. They provide a structured, well-informed, and standardized approach to diagnosis, treatment, and prevention, which is especially critical in regions such as Latin America, where infectious diseases like rabies still pose a significant public health threat. The case right now in Arequipa, Peru, is good to remember that. And our dedication to this is important in the context of the collaboration with the different societies, and it has been discussed yesterday. It's important the multidisciplinary approach between health in humans, animals, and the environment for the One Health approach, which is key for that. I would like to say for my last couple of slides, I would like to invite all the people. we will have our Latin American Congress of Trial Medicine in August 2024 in Rio de Janeiro, Brazil. And we will have specifically a presentation and a session also of vaccines and obviously of rabies. And this is my last presentation to invite you not only to visit again Colombia, but in the future going to the Coffee Triangle region and other regions of the country. And here the poet Luciano Garcia Gomez says in Pereira, there are no foreigners. We are all Pereirans. Thank you very much.
Bueno, muchas gracias, doctor Alfonso Rodríguez, por su presentación. Vamos entonces a dar a continuación la presentación del doctor Wilmer Villamil con su presentación que es Clinical Approach to Rabies Under the One Health Lens. Bienvenido, doctor Wilmer.
Muy buenos días, gracias por tan excelente invitación y pertenecer a este comité científico. Especial mi agradecimiento a la doctora Natalia Cediel, a la doctora Verónica del comité central y nuestra máxima representante. Tengo una misión y es entrelazar el enfoque clínico de la rabia bajo la óptica One Health. Y vamos a empezar por un caso clínico. Nuestro caso clínico, paciente de sexo femenino, 22 años de edad, natural y procedente de la comunidad indígena de Yacutins, afluente del río Morona, con pocos kilómetros de la frontera con Ecuador. ¿Qué encontramos en el examen clínico del paciente? Encontramos una presión 144/91, frecuencia cardíaca 104, frecuencia respiratoria 20, temperatura 36,7 y nos está saturando perfectamente bien. Datos importantes, taquejumbrosa, dolor abdominal y sensación de falta de aire. Ojo óptico clínico. Al neurológico, fuerza muscular conservada en miembros superiores, pero fíjense la disminución de la fuerza en ambos miembros inferiores, aunque los reflejos están disminuidos en ambos miembros, Hoffman y Babinski son negativos y no hay rigidez de nuca. Antecedentes de importancia: contacto con murciélago a los 7 años de edad, es grávida 5, para 5, abortos, parto 5. Y se hace una impresión diagnóstica también para tener en el tintero de análisis debilidad muscular de inicio agudo, parálisis flácida aguda. Esa es la impresión diagnóstica inicial. Entonces viene la primera pildorita. Cuando consulta el paciente al servicio de urgencia, clave, y nosotros en infectología lo utilizamos, la fecha de iniciación de los síntomas. Entonces van a ver ustedes que vamos a empezar 7 días antes de la consulta y van a ver ustedes en el espectro clínico la importancia que tiene de los 7. 7 días antes de su consulta, por eso pregunta, ¿cuándo fue la fecha de iniciación de los síntomas? ¿Qué síntomas presentó usted? Entonces nuestra paciente, dolor en los tobillos derecho, una intensidad de dolor de 6 a 10, o sea que sí había un dolor considerado, que se irradia a piernas sin antecedentes recientes de mordeduras. 5 días antes. Dolor de las mismas características que se presenta en el tobillo izquierdo y se irradia a la pierna y se presenta en ambas rodillas acompañado de prurito. 4 días antes, dolor que progresa hacia los muslos y la cadera, dificultando la deambulación por la flacidez muscular. 3 días antes, síntomas que persisten y se asocian ahora a prurito, dolor en mi abdomen inferior, tipo punzante. Y un día antes, cuadro de cefalea 7 a 10 intenso, característica pulsátil, dolor abdominal en epigastrio, tipo cólico de baja intensidad. Ya llega el D sub 0, que es el motivo de la consulta. Entonces, clave, fecha de inicio de los síntomas y qué síntomas inició. Ya lo analizamos en el examen, el diagnóstico. Entonces, con esa impresión diagnóstica de debilidad, vamos a hacer la punción lumbar. Se punzan y mire la característica importante que tiene las proteínas, 493 miligramos por litro. Y como el profe Alfonso había comentado, clave el TAC, característico un edema cerebral, lo cual se caracteriza esa encefalitis. Y fíjense ustedes que no podemos diferenciar los ventrículos laterales, no hay una anatomía, hay un gran proceso inflamatorio a nivel cerebral. Y entonces ya con esto llega y se hace la impresión diagnóstica de rabia silvestre transmitida por murciélago. Y algo clave que se debió, a pesar de no haber la mordedura, ellos echan en las alitas, está fresco y a veces no se siente, pero miren ustedes lo que uno observa en la mordedura del murciélago en cuero cabelludo es esta lesión. Con esto ahora vamos al escenario, cuál ha sido la evolución, cómo manejamos al paciente, y entonces vamos a ver que ya del día 7 mejora la diuresis, pero se estabiliza el sodio sérico, la pupila persiste midriática, o sea que hay un compromiso bien severo a nivel del sistema nervioso, se reduce la sedación, día 10, periodos de taquicardia, bradicardia, hipotermia, se suspende ketamina, se reduce la sedación, pero lamentablemente presenta sistolia súbitamente y la paciente fallece. ¿Qué escenario importante tenemos que analizar? Hay que tomar biopsia y hacer la prueba gold standard de confirmación. Se toma la biopsia del cerebro y verdaderamente se confirma positivo para virus de la rabia en tejido cerebral. Y ayer vimos con el doctor Brito que nos hablaba de este desmodus rotundo y es clave en el murciélago porque empezamos por ahí. Son murciélagos hematófagos que fueron los causantes de esto y viene entonces vamos a integrar y empezamos con el chisme epidemiológico que yo le digo a mis estudiantes. Chisme epidemiológico. ¿Ha estado usted, ha presentado mordedura, ha estado en contacto con algún animal para poder integrar? Y es que cuando tenemos el murciélago es clave bajo la óptica de Wangel que hay que intervenir en el murciélago. Primero, hacer una georreferenciación, el área donde se encuentra, capturarlo, identificarlo y utilizar varias sustancias y movilizarlo con anticoagulante, ¿cierto? Para, digamos así, hacer la caracterización, inmovilizarlo y hacer la campaña del control del murciélago. Y traigo este artículo importante de las rabias por murciélago hematófago. Vean ustedes, en este primer slide tenemos a la gran camada de estos murciélagos hematófagos que cuando se hace la investigación de campo en los sitios donde se encuentran, lo podemos localizar. Y es así nosotros aquí en Colombia, este artículo importante que es el brote de rabia humana transmitida por gato en el municipio de Santander de Quilichao, pero también tenemos a nivel de Latinoamérica que los murciélagos hematófagos son causantes también de brote y miren todos los países los cuales son afectados, entre estos Perú, México, Bolivia y nosotros en Colombia, en la región Caribe. Entonces viene segunda pildorita, ya identificamos, georreferenciamos bajo la óptica Wangel animal, lo inutilizamos y hacemos la campaña. Ahora vamos a hacer algo importante que es la estratificación del riesgo de la rabia. ¿Cuáles son las variables que utilizamos? Tenemos la primera de laboratorio, ¿cierto? Que es importante y una variable muy importante, el porcentaje de vacunación. Fíjense que si tenemos porcentaje y tenemos un puntaje del 25%. Otra variable importante es la circulación viral en humanos. Sin circulación es 5%, pero cuando tenemos linaje silvestre en animales, 15%. Y cuando hay una, digamos así, hay una producción silvestre diferente, nos da el 20%, y cuando hay cualquiera condición con linaje, sea perro, zorro o humano, nos da el 25%. Todo esto nos llega a apalancar en estratificar el riesgo para realizar una excelente intervención. Entonces ayer vimos, ¿qué es One Health? One Health bajo la óptica no es más que es un pensamiento, más que una estrategia, es pensar yo cómo hago para intervenir varios actores y así poder intervenir una enfermedad de impacto en salud pública, en este caso la rabia. Entonces fíjense ustedes que la comprensión más profunda, los vínculos y las relaciones con una interacción y comportamiento entre los elementos que caracterizan todo el sistema. Fortalecer el sistema de salud. Por favor, las historias clínicas son un abordaje integral del paciente, un abordaje con una excelente anamnesis, una buena identificación de los factores de riesgo y no esperar que pasen los días para que haya el desenlace. Reducir la duplicación, exactamente, ¿qué es esto? Que tiene que manejarse un sistema de información conjunto. Si con ICA identificamos al murciélago con el sistema que nos explicó la doctora Diana Waltero ayer del sistema de nuestro Civigila, articularlo y con nosotros los clínicos que hacemos el abordaje de los pacientes en los servicios de urgencia. Y es así como viene la otra, hay que tener la red diagnóstica importante. Vean ustedes que se punzó el líquido cefalorraquídeo, pero también podemos hacerlo en el caso real-time PCR en saliva o la determinación de los anticuerpos, que es una medida de diagnóstica importante. Y viene el otro escenario, que sé que va a haber un simposio sobre el protocolo de Milwaukee, pero indudablemente en este paciente la alternativa que lo utilizamos, fíjense ustedes, vacuna, inmunoglobulina no recomendado, la sedación se recomendó, se inició, se retiró la sedación y la medicación con ketamina, en este caso midazolam, aroperidol y amantadina, que es el protocolo de Milwaukee. Esta slide nos muestra algo clave importante. Fíjense desde la exposición que puede haber un periodo entre 20 a 90, pero va a haber unos pródromos que duran 1 a 2 días, la fiebre, el prurito, la parestesia, y fíjense ustedes que la primera sintomatología que ocurre de 1 a 4 días es el compromiso neurológico con cuadriparesia, disartria, disfagia, compromiso respiratorio, y fíjense los 7 días el paciente, si no actuamos, el paciente fallece. La ley de los 7 días es importante. Por lo tanto, en la óptica de One Health vamos a interactuar lo que son el componente tanto animal, el componente del agente etiológico y lógico, el factor humano, pero inmerso en una excelente atención clínica y llega en algo que nos mostraron ayer, que es la famosa vigilancia veterinaria, porque no podemos estar aislados de los médicos veterinarios, porque son ellos el primer contacto a veces. A mí me mordió mi mascota, el gato, pero ella es que tengo Pepe, es callejero y le gusta salir y se me pierde. Ay, yo lo tengo aquí en el apartamento y me mordió. Ahí eso es un factor de riesgo estratificar para poder pensar y articular One Health. Ya el profesor Alfonso, en este paper hablábamos de unos objetivos, que es lo que quiero resaltar. Y quiero resaltar los objetivos para intervenirlo en One Health, un objetivo importante que es clave, determinar y hacer una vacunación desde los animales. Otro objetivo que es clave es tener una acción en los servicios de salud, tener una acción integral, de una atención integral basada en las guías, con unas excelentes profilaxis que se hagan oportunamente y una buena data para tener una intervención muy buena. Entonces, hacemos el camino, ¿cierto? Declaramos las zonas, ¿cierto?, que están libres. Posteriormente hacemos la investigación de las características, la georreferenciación, en este caso el hábitat del murciélago. Hacemos las acciones de vigilancia, identificamos el riesgo y manejo adecuado, ya eso se hace desde el punto de vista clínico, que un buen lavado de la herida con agua y jabón. Yo siempre le digo a mi estudiante, el jabón de pino, jabón de azul, es un jabón clave que es importante, lo importante es realizarlo, y si no tengo yodopovidona en mi servicio de urgencia, yo lo tengo que realizar. Hago acciones de vigilancia programada, vigilancia con el ICA, vigilancia del agente etiológico y hago las alertas tempranas, que las disparo, pero que sea una alerta al unísono, que estén conectadas, y las 4C que la doctora Natalia Cedial nos enseñó: una buena comunicación, una buena coordinación y una capacidad de reacción muy importante. Y así colocamos, teniendo como base todo el entorno de un ambiente urbano, de un ambiente rural silvestre, y que nosotros los humanos nos internalizamos en este ambiente. Por lo tanto, vamos a ver que corremos el riesgo en cualquier momento con esto de ecoturismo, nos vamos a ver inmersos en los ambientes. ¿Qué hay para llevar a casa en el celular? Estrategia regional de la OPS contra la rabia canina. Implementar campañas masivas de vacunación canina, lo vimos nosotros en el objetivo, y anualmente la cobertura vacunal al menos el 80% de la población. ¿Vieron los informes del ICA? Tenemos cobertura del 97%. Nuestras coberturas están bien, pero nuestro vecino país, Venezuela, con unas coberturas totalmente bajas, por ahí se nos puede exactamente filtrar. Hacer un aseguramiento de atención efectiva en personas expuestas y mejorar la calidad y disponibilidad de las inmunobiológicos. Hacer un fortalecimiento de la vigilancia y capacidad de diagnosticar, por favor. Esto es clave. Si no hacemos, nosotros no podemos hablar de elefante rosado si no lo hemos visto. Y tenemos que hacer una buena historia clínica con una buena anamnesis, hacer educación sanitaria. Yo en el componente de la doctora Natalia Cediel, comunicación. Y una palabra que me gustó ayer del doctor Vigilato, comunicación, que es importante, educar comunicando. ¿Qué vamos a hacer? Implementémoslo, porque aquí es donde viene el problema. Tenemos que tener características de implementación. Si no implementamos en nuestro servicio, en nuestros sitios donde nosotros estamos, en nuestras ciudades donde no estamos, todo queda en una charlita. Por lo tanto, implementar. Y los pasos a seguir bajo la óptica de One Health, hacer esta implementación, declaración del problema. Y ya lo hemos visto, la región Caribe, nosotros tenemos Santa Marta, el Magdalena, La Guajira, la población guayú, que preguntaba la doctora Verónica, ahí tenemos una población de los indígenas. Los indígenas no pueden quedar, por favor, por fuera. Entonces ya lo identificamos, exploramos el campo, ponerse las botas y hacer investigación de campo, hacer un problema de encuadre, mapearlo, y aquí utilizamos nosotros en nuestro Centro de Investigación de Ciencia de la Vida, tenemos el laboratorio fuerte de robótica y de inteligencia artificial para mapear cuáles son los sitios y mapear también los animales, dónde están, para caerle exactamente todo el equipo, definir los objetivos, y hay que hacer una matriz de priorización. No podemos a la topa tolondra, si no vamos a ver, gatos nos está aumentando. Vamos a priorizar entonces gato y vamos a establecer las acciones, establecer opciones de intervención, seleccionar las intervenciones, identificar los indicadores de progreso. Ese es el otro problema, no medimos lo que hacemos, no establecemos unos indicadores de impacto, entonces no sabemos cómo vamos. Identificar, acordar el plan de acción, quién es el responsable, con tiempo, organizar reuniones periódicas. Nosotros, yo presido, soy el presidente del Comité de Medicina Tropical, Zoonosis y Medicina del Viajero de la Asociación Colombiana de Infectología. Estamos 365 días y viene la otra pildorita. Hay que crear la red de expertos en rabia, que funcionen, que consulten para apoyar a cada uno de los médicos de los diferentes servicio. Y uno de los medios que tenemos es exactamente el WhatsApp. El WhatsApp nosotros funciona las 24/7, 365 días al año. Evaluar el progreso y comenzar siempre desde arriba usando los resultados de evaluación. Sé que hay colegas peruanos importantes. Tenemos un equipo, no solamente lo hacemos en Colombia, lo hacemos con los amigos de Perú, ¿cierto? El doctor Martín Caspia, doctor Juan Celi, que es el actual presidente de SPEI, de la Sociedad Peruana, y mantenemos la famosa teleconsulta de medicina tropical y del viajero. Y en una de las patologías, ya el profe Alfonso lo dijo, Perú, Arequipa no tenía rabia humana, actualmente hay casos de rabia humana. Entonces la red no solamente de Colombia, sino hacer la red latinoamericana. Muchas gracias, Dios me lo bendiga y esperamos una mesa redonda bien animada. Hay fila, estamos de pie.
Doctor, muchísimas gracias por su presentación. Para estas dos primeras presentaciones, debido al tema del tiempo, no vamos a poder realizar las preguntas. Si de todos modos tienen alguna pregunta o comentario, la podemos hacer al final, después de los siguientes médicos que van a presentar. Entonces, ya le doy el paso a mi compañero de mesa para que él continúe presentando a los que siguen.
Thank you very much. So we're going to move on. So we have 15 minutes for each presentation, including the questions, and the questions are going to immediately follow the presentation. So Dr. Stephen Skolin from Rabies Free World is going to give a presentation entitled Human Rabies Risks Following Exposure, Development of a Rabies Homunculus Using an Artificial Intelligence Tool. Dr. Skolin.
Muchas gracias. Buenos dias. Good morning, everyone. Thank you, by the way, to the Rita Organizing Committee for inviting me for this talk. And also extreme thanks to the administrators and the people behind the scenes, because as you probably know, these conferences are a nightmare to organize and to run. I wanted to ask, are there any artists in the group? I know we have a diverse audience. Some, hopefully. I'm interested also in your feedback on this. But what I thought we could do is look at human rabies risks through the development of a homunculus and using artificial intelligence to perhaps help that out. Just as some quick disclosures, I do work as a consultant for some industry, and my daughter, who is actually an artist, helped me with this. So of course, rabies transmission depends on various factors. Of course, the biting animal, the types of wounds, the depth. I've got a picture of Joseph Meister up there, the first patient of Dr. Pasteur, who was bitten multiple times. Certainly the anatomical factors, I think when you consider the nerve distributions, the central nervous system, and then other factors. What about the biting itself? Is there such a thing as a dry bite in rabies, such that if you get bitten by something, how much virus might be inoculated? Could you get lucky somehow and have a very low amount of virus injected? Certainly, I think viral strains, when you look at dog strains, street virus versus bat strains, what does this do to the brain when you're looking at autopsy? This is a factor. And then other clinical factors that may result from the doctor's management. Timing, I think of the recent failure case in the United States. A patient waited 3 days before getting prophylaxis. How bad is that? Could there be other factors? And I want to ask you, what factor do you think of these is the most important? And just considering pathogen, germ, and patient, there are, of course, overlapping features of these. But for me, I think the anatomical factors are probably the most important. And certainly we can debate about this when you consider that rabies virus and other lyssaviruses are neurotropic. That's what they're looking for. Try to get into the nerve, get to the brain. So something like a scratch or a bite, I think this is very relevant. And you think about the distribution of the peripheral nervous system, where are the highest density of nerves, how close you might be to the central nervous system when you think particularly about cases where the dog jumps on a child on their head, maybe puncturing the eye or directly into the central nervous system, such as through the skull. Obviously, this would be a higher risk. So I would ask you, okay, well, which of these rabies exposures do you think would be more worrisome? And as a clinician at the point of care, what sort of call to action are you going to follow? Certainly, I think the picture of the child with a face being extremely severe, and this is something that we try to push forward, and maybe you agree, maybe you don't agree, but shouldn't there be a category 4 rabies exposure. I mean, you think about that, wow, kind of scary, and what can we be doing to sort of highlight this for the clinicians? So I thought the development of a rabies homunculus might sort of make it clear in terms of the neuroanatomical risks and help the clinician at the bedside to inform the post-exposure prophylaxis. And certainly there's issues with that. You think about the availability of rabies immunoglobulin, particularly as a neglected tropical disease around the world, but certainly we've seen the tragedies. What is a homunculus, you might ask? Probably most of you know, but it is Latin for little person, and it actually was a concept pushed forward by the alchemists in the 16th century, Paracelsus. And if any of you have been through neuroanatomy, there's the cortical homunculus, which I think is somewhat famous, shown here. It's actually quite old, however, and recent literature says that this is actually not very accurate at all. And in fact, the cortical homunculus, the motor homunculus, probably looks a lot more like this when you consider brain mapping and what all the controls are in the brain, something quite unusual looking. Now, I actually tried to make a rabies homunculus back in 2004 when I interviewed with Dr. Ruprecht at the CDC. And basically what I tried to do was use geometric sizes based on data, which Dr. Jackson, I actually lifted that out of your earlier version of your book, that looked at archived data from rabies exposures back in the 1940s. You know, if some person was bitten, what was their progression to rabies, sort of all things considered. Certainly there's different reviews, and these are some of the major ones. I think we could do with a massive meta-analysis to nail this down a little bit more, or perhaps a prospective study that would look at that, but essentially just using what was out there and putting that into an artificial intelligence program. And I don't know if you guys are using artificial intelligence. Obviously, this is the next wave. I do personally try to use it every day, and I think that we should be, you know, don't want to be left behind. Try to use it even for like a shopping list or something like that. It is quite helpful. So we looked at a couple different graphical programs, DALL-E, Dream Studio, Night Cafe, a few more, and then basically put in the information that we had and see if this could transform into a homunculus. And then, you know, using what the machine came up with and then, you know, comparing it to humans just to see. The first program that I used was DALL-E 2, and this is one of the OpenAI programs that basically goes from text to a drawing. And so I said, all right, well, make a homunculus figure showing a head size enlarged 50 to 80%, hand or finger size 15 to 30. This is the initial output. And I'm like, what? You know, what is this? It just seems quite strange and unusual. It's coming up with text that doesn't make any sense. On the second go around, I said, all right, well, try creating a small human figure with some of these features. And this is what I got. You know, of these images, maybe the baby, you can sort of expand that. You can ask the program to continue on. Then I said, all right, well, you know what, that's not very good. How about if you just revise this initial figure? And it couldn't do it. So you could see it as strange writing, these, you know, variations. So gave up on that one. All right, let's try Dream Studio, which is what all the major artists seem to like. It's one of the bigger programs. And it does have a number of nice features, including, you know, a manga, you know, Japanese cartoon template if you want to use that. And basically what you do is you type in what you want to do, and then it's going to create images. So I said, all right, well, how about a human figurine based on proportions for rabies risks? There you go. And look at this. I mean, it seems quite insane, almost like an LSD trip. Look at the hand with the face on it and all sort of strange distortions. So I thought, all right, well, what can I work out of this? Let's take this model and maybe work from that. But you'll notice there's a hand appearing in the buttock region. There's a third leg. The hands themselves are wrong. So you ask the program to sort of refine it. It's now changed the leg to a tail. The hands still aren't right. You can ask it to streamline a little bit more. And it does come up with different versions. This is just one of the versions where I said, well, just for fun, make the eyes look bigger and make it scarier. And this is what we come up with. So I don't think this should be our rabies homunculus. I really don't. But maybe it has other applications such as, public health and awareness and trying to get the message out, because certainly rabies is neglected. We need that attention, particularly with 2030 approaching. So I thought that, the AI programs were less than satisfactory. Dream Studio, to me, seemed to be the best. But the problem, as you may know with AI, it makes stuff up. It hallucinates, doesn't always do what you say. I mean, some of those figures, I asked it to rotate by 45 degrees, didn't do it. As some of the recent medical literature shows, that it is something of a black box, and, how do we really get around this? I think it is useful, though, for creativity, for ideas, just sort of changing some of those thought patterns. So it is helpful, but of course, limited. So I thought, all right, we'll go back to the drawing board. How about a human image? Basically using the same principle, using graph paper and trying to get those proportions. I did use some AI to clean up the image. You can see the before and the after. That's Cleanup Pro. But then when I said remove the grid lines, oops. So I got blocked. So kind of interesting, maybe it was concerned about privacy. But I think in conclusion, a rabies homunculus would be useful for the clinician, particularly when we're thinking about category 4 and how to triage some of these patients. Certainly the AI landscape is changing. I'm sure 5 years from now, it's going to be absolutely phenomenal. But I do encourage you to get in there, you don't want to be left behind. And I think for now, a human rendered homunculus is what's best. So thank you. I'd like to take some questions if there are any.
We have 3 minutes for questions. Are there any questions? Well, I'll ask the first one then. Do you think this is really going to affect management at all?
That's a great question. Might this affect management? I think it could. I mean, when you think about my colleagues at the bedside, I mean, we're all experts here, so we know everything about rabies. But I think in large part, some of the clinicians that I work with that I know are, dare I say, clueless. And I think about, some of the management, and you just, you backtrack and you think, oh my God, well, I'm glad this wasn't a real rabies exposure because they screwed it up. Or the failure case in Minnesota. What exactly happened there? There are some reasons for that, but I think it's worth doing. And I think if anything else, it does sort of promote our field. Here's something new that might be helpful.
We have time for another question. Are there any questions? Go ahead. You need a microphone? You see my microphone? Right there. Needs a microphone. He needs my microphone?
Yes, I'm sorry.
Muchas gracias, buenos días. Dentro de las investigaciones que están haciendo, ¿cierto? Y ustedes están pues utilizando lo de la inteligencia artificial, ¿qué investigaciones están haciendo o qué se debe implementar respecto, por ejemplo, a la adaptabilidad o a la mutación del virus, ¿cierto? Porque el virus se puede establecer en una comunidad y se puede adaptar, se puede volver resistente. Entonces, ¿qué investigaciones se deben implementar o qué procesos se deben realizar para evitar esto o para contrarrestar este problema del virus?
I'm sorry.
Eh, ¿Puedes, por favor, repetirnos la pregunta para que el doctor pueda, ya con el traductor, pueda comprenderla? Muchas gracias.
Que dentro de estas investigaciones que están realizando, ¿qué se debe implementar para evitar o para contrarrestar el problema de, por ejemplo, cuando el virus se vuelve más resistente o muta, ¿cierto? ¿Qué se debe hacer o qué se está implementando para evitar pues este problema con este virus?
Thank you very much. That's a great question. I am a clinician at the bedside, so I really don't have much to say about that. What I think is rabies being neglected. We need attention, we need money, we need funds, and I'm sure you've heard that before. But think about it. I mean, Pasteur developed the vaccine in the 19th century, and since that time, except for Dr. Willoughby, what else has been done for rabies treatment? I mean, it's all washed away. So I think maybe trying to get some more attention for our field would be helpful.
Thank you very much. I think we need to now move on. Our next speaker is Dr. Susan Moore from the University of Missouri, and her presentation is Comparison of International Rabies Antibody Reference Standards. Dr. Moore.
Thank you, and I want to thank the organizing committee for allowing me to present this study. So as the title says, I will be talking about international standards for rabies serology. And the reason we use international standards is so that we can report results in the potency of a result in an internationally agreed unit, which is the IU. This allows direct comparison of results between laboratories. So this is a slide that just shows the history of the WHO SREG references from the first one in 1955 to the most recent one established last year. So how do we assign potency? Well, interestingly enough, the first one was an equine product, and there was nothing to compare it to. So it was assigned a potency of 86.6 just based on the weight of the material in the ampule, which was 86.6 milligrams. Every other WHO reference standard has been determined by interlaboratory testing at various potency levels and in replicates by comparing to the previous one. So the first one was compared against the equine product, then the second against the first, and the third against the second. Most of them were established, the potency levels by RIFIT testing, even though some of the other studies included different methods like the mouse neutralization test, the potency was determined by the RIFIT results. Up into the third one, where a number of assays were used, and there were two potencies assigned, one based on a combination of the RIFIT and FAVN results, and a separate potency based on the ELISA results. There are additional ones that are available internationally. The one by the European Directorate for Quality Medicines in Healthcare, or the EDQM, and then it's a human source, and then the WOA standard, which is a dog source. So the first one was back in 1983, so a long time ago. So there has been some periodic comparisons performed between 1989 and 1993, and then when WHO 2 was established, the FDA compared the two again in 1997 and identified a little bit of a decrease in the WHO 1, and this continued to decrease, which was determined by studies in 2006 and 2012 at 12% and then 19%. And during this time, 1993 to current times, both the products are presumably used in laboratories. The quantities dwindled down to zero which instigated the preparation of the third international standard. A reason to compare the standards internally is to understand the degree of agreement for your internal quality control procedures, so you can track and trend the assay and the reagents, and then variation in potency measurement by assay type. Externally, it's important because we're comparing data sets for things like vaccine clinical trials, surveillance data, and product potency. So it's very important to know externally how they compare. So in our study, we used the ones that were available to us, which is the third WHO, EDQM, and WOA. We diluted them to 2 potencies. We were graciously provided the second WHO2 at 0.5 by Dr. McAheen's laboratory at APHA. We tested by 2 serum neutralization tests, the RIFID and the FAVN, which were validated in our laboratory. And we used a commercial ELISA kit, indirect ELISA, which is the Bio-Rad platelia, which is commonly used throughout the world. We diluted them. We tested them in duplicate in 3 independent assays. We used the geometric mean titers for the serum neutralization assays, or the average of the EU values, to then calculate the % difference in pairwise comparison between the different sources of the SRIG. So these are the results of the serum neutralization test. And with the FAVN and the RIFID, we can see there's differences in the geometric mean titers between them, both at the 2 potency levels. And we did see that there was a really pretty good comparison between the EDQM and the WHO. I'll just mention that those are the 2 most recently established ones. I don't know if that has an effect, but we did notice that. To start to look at what the importance of this variability, we first wanted to look at the average difference from the same source. So we ran them in replicates. We took all of those together, we pooled them together. Here we looked at them by FAVN and RIFID, very similar % differences. So the average variability, I guess you could say, of the same source of SRIG is 11.1%, which is this line you see in the figure. So this is our baseline variability. And then the bars show the pairwise comparisons. So as I said, the third WHO compared very good to the EDQM with only a 16.3 average % difference, and then a higher between the EDQM and the WOA, and then even higher between the WHO third one and WOA. So to look at it another way, we wanted to determine an interlaboratory comparison. So we used the samples that we received. You can see, using the exact same source, the WOA's exact same source, in 2 different laboratories, prepared in this laboratory and in this laboratory, we get very good agreement. Interestingly, both WHO3 and EDQM were qualified against WHO2. You can see they're similar, but there are differences. Where it's same source, you get a very good comparison. We get the same story when we look at indirect ELISA. We see the differences in the SRIG values, although we see a better comparison between EDQM and WOA on ELISA. So that's the assay difference we'll see. We have the SRIG differences and we have the assay differences. So why do we compare? Well, as most people know, your SRIG value is your line in the sand when you're going to say this sample is equal to or above 0.5 or it's below 0.5. So that SRIG value is very, very important. What we did was we took a set of results, titer results, we calculated the IU values using these different SRIG sources at different potencies. And we can say, if we use the third WHO, more of the samples showed seroconversion compared to EDQM, but was very, very, very comparable. But if you use WOA, you had a lot less seroconversion. And then we calculated the seroconversion with ELISA, and it was 58%. And it matches really well with the WOA. So in summary, there are differences above the average difference between same source, which was 11.1%. Best agreement was between WHO3 and EDQM. We had the biggest difference, which was the 52.9% between WHO3 and WOA. With ELISA, again, intra variability was 11.4, and we had really good comparison between EDQM and WOA. So assay variability is a consideration for assigning cutoff values, and seroconversion of an individual sample or percent seroconversion of a group of samples is really dependent on that SRIG value. So we need to track them, and because the variability may impact interpretation and comparison of results. And when you're going to switch between different sources, you may want to consider this as well. So ongoing monitoring is really important because there's no assigned expiration date of international standards. So ongoing potency monitoring is important, both intra and interlaboratory. Laboratory exchange programs or proficiency programs is a really good opportunity to track these drifts and shifts of results over time of these products. So, and that's all I have.
Thank you. We have a few minutes for questions. We need a microphone. Dr. Ruprecht needs a microphone.
Thank you, Dr. Moore. Can you hear me?
Hello?
Very nice presentation. Given all the eccentricities of the Rift and FAVN, et cetera, do you think our regulatory officials, either nationally or globally, can appreciate this and the significant impact that it could have on clinical trial importance? And similarly, when you reported previously from 1 to the 1,000th unit of significance, I can see the importance of the 10th of an IU. So one, regulatory relevance, understanding, and two, what's your interpretation of how many significant units we should be going with IUs? Thank you.
Yeah, and that's a really good question, and I think that relates to just the overall attention to rabies. And so regulatory officials are looking at multiple things and prioritizing them. In my experience, some, depend on their experience, understand it, some not at all, not at all. So, establishing what's an appropriate significant difference. What's the significant difference?
I mean, for example, one of them went to the 1,000th. When you looked at that one, I think it was the WOA canine, reported it to the, not 10th, 100th, but it reported to the 1,000th of an IU. In your experience, what,
Yeah.
the 10th is relevant, but do we need to go that far?
I understand what you're saying, and there's not really a global understanding. Each laboratory has to establish that based on their own validation parameters. For RIFIT, commonly used and published would be for CV is about 30% for RIFIT, but for FAVN it could be higher. So.
Bueno, acá tenemos dos preguntas en español. Hay una que dice, ¿hay una potencia estándar en el mundo? Organización Mundial de la Salud. ¿Se refiere a la prueba Gold Standard? Si nos puede, por favor, aclarar quién hizo la pregunta. Sorry, doctor, I am going to, because the questions are in Spanish.
Okay.
So I'm going to understand first the question and then tell you.
Que si existe un nivel de potencia a nivel mundial ¿Y qué pasa si se usa una menor potencia?
Pero te refieres a la potencia de la prueba.
Sí, de las vacunas.
Ah, ok. Okay, doctor. Do you know if exists a potential and standard vaccine, a vaccine that is potential and standard in World Organization of Health?
Are you asking about a standard for the vaccine potency? Yes, there are international standards available for purchase through the NIBSC organization in the UK that are vaccine standards. So antigen standards, is that what you're talking about?
Okay.
Yeah.
Okay.
I hope
it's
that was the
clear for
question.
you?
Okay.
Okay, and the second one, it's if maybe this standard vaccine has a less potential, what may be going to happen with this type of vaccine? What do you think about it, doctor?
You mean the effect of the antibody standard on the vaccine?
Yes.
Okay, so as I mentioned, when you're comparing data sets and you're using one SRIG compared to another, if one is lower, the SRIG is lower, it's going to cause your percent seroconversion to be higher. And that's what I was showing in that slide. So I can show you a little bit later in detail.
Okay, thank you. We're going to move on to our next speaker.
So thank you so much. I'm going to introduce Dr. Luis Polo, and it's going to talk about cultural practices related to aggression by potentially rabies transmitting animals in Colombia from 2007 to 2009. Thank you so much. Muchas gracias.
Bueno, muy buenos días. Bienvenidos a Colombia. Muy duro.
Bájale un poco. No sé. Un poquito más bajo.
Alguien preguntaba anteriormente por un artista, tengo voz cantante.
Toca que hables más bajito. Porque
Ok.
se cruza con la voz que ellos escuchan en el radio.
Ok.
Mira señalador.
Bueno, muy buenos días. Bienvenidos a Colombia. De antemano agradecer a los organizadores, al comité científico, a la Universidad de La Salle, a la doctora Natalia Cediel por la invitación. Esta es una mirada diferente de muchas cosas que suceden alrededor de los brotes de rabia en mi país y que muchas de ellas no se han publicado. El antecedente no avanza.
Tienes que bajar.
Ah, ok. No.
No sé cómo hacerlo para que se pase.
Tenemos un antecedente en nuestro protocolo y la guía de manejo y sabemos que las agresiones y mordeduras por animales domésticos son consideradas una urgencia médica y hay que tratarlas como tal. Las personas agredidas deben ir inmediatamente al servicio de salud para recibir la valoración, tratamiento de la herida y valorar la exposición al virus de la rabia por parte del médico tratante. En Colombia existen y han existido prácticas e imaginarios culturales alrededor de la atención de las heridas producidas por animales domésticos y animales salvajes en nuestras comunidades y también en el mismo personal de salud. Estas prácticas han constituido una barrera de atención oportuna en el tratamiento de las heridas. En muchas comunidades campesinas donde no hay circulación viral, pues no se conoce la enfermedad, no hay noción del riesgo de transmisión de la enfermedad, es desconocida o está invisibilizada. El objetivo de este estudio fue comprender e interpretar las prácticas culturales de las comunidades asociadas a la atención de mordeduras ocasionadas por un animal doméstico o salvaje. Y el trabajo de campo se desarrolló, esto es una experiencia de trabajo atendiendo los brotes de rabia durante los años 2007-2009, haciéndole seguimiento a las agresiones por animales potencialmente transmisores de rabia, y la información se recopiló a través de encuestas, charlas, relatos, entrevistas e intercambio de conocimientos con los familiares de las víctimas y con los padres de los niños afectados. Vemos aquí en el mapa, para que nuestros visitantes puedan comprender, durante los años 2007-2009 se presentaron 7 casos de rabia humana y unas situaciones particulares de agresiones. En el 2007 se presentaron en el mes de enero los 2 casos de los 4 casos de rabia en el departamento de Santa Marta transmitido por variante 1 perro. En San Luis de Palenque, Casanare, se presentó un caso de rabia humana en una señora transmitido por murciélago hematófago. En el año 2008, en el departamento del Cauca, se presentaron 4 casos de rabia humana, 3 en el departamento de Cauca, perdón, y 1 en el departamento de Santander. En Cauca, Santander de Quilichao, 2 niños muertos por mordedura de murciélago variante 3, de murciélago hematófago. Bolívar, Cauca, una niña también mordida por murciélago variante 3. Y en Santander, un niño mordido por un murciélago bebé variante 3. En Florida Blanca, Santander, exactamente. En el año 2009 se notifica el primer caso de rabia humana en Colombia transmitido por murciélago insectívoro en una señora, y casos particulares de Santander, una agresión por mordedura de gato, vamos a analizar más adelante, y la comunidad indígena de los Tucanos Occidental en el Bauspés, agredidas por murciélagos hematófagos. En este cuadro resumo cada una de las situaciones. En primer lugar, la circulación viral en cada uno de los sitios, circulación, no circulación, la variante viral involucrada, la especie animal mordedora involucrada en cada uno de los casos, la asistencia inmediata al servicio médico. La gran mayoría de los casos no asistió al servicio médico, solo en 2 de los casos, y la consulta al servicio médico se hizo en forma tardía, 3 meses después, en el distrito de Santa Marta. Santander de Quilichao fue al servicio médico inmediatamente, pero la atención fue deficiente. Y la misma situación ocurrió en Bolívar, Cauca, donde no fue catalogada como urgencia la agresión por el gato, y lastimosamente la persona desarrolló la enfermedad. Entonces, vemos también que las personas que no acudieron de forma o no acudieron al médico, estos fueron llevados por sus familiares, hicieron un tratamiento casero. En la gran mayoría del territorio colombiano vimos durante la investigación de campo que la atención casera fue con aguasal, alcohol, y se aplicó en la mayoría de los casos limón. Lo que nos encontramos en las entrevistas, el limón es bendito, lo cura todo. Bueno, eso por este caso. Y estaba tan de moda para el año 2008 el éxito del protocolo de Milwaukee en Gina Gysi en el año 2004, y por falta de actualización se aplicó en pacientes de Santander de Quilichao. Un niño mentiroso, nunca estuvo expuesto a la mordedura. Hubo una mala valoración de los factores para el análisis de la exposición al virus de la rabia, y fue sometido al protocolo de Milwaukee. En Matanza, Santander, un gato estaba muy bien en la mañana, se metió debajo de unas tejas, salió botando babasa, mordió a un niño, una clara intoxicación. Se detecta este paciente a los 7 días con fiebre, dolor de cabeza, producto de la infección por la mordedura, y no se hizo un análisis de la exposición. Entonces, este niño inicialmente recibió un tratamiento casero, agua, alcohol, sal, alcohol y limón. No se hizo la valoración, no se hizo el diagnóstico de confirmación de la enfermedad, se aplicó el protocolo de Milwaukee. Cuando se dan cuenta del error que han cometido, tratan de despertar al paciente y se complica y muere. En la necropsia, en los fluidos respiratorios, se confirma el hallazgo de Pastorela multocida, habitante normal de la cavidad oral de perros y gatos. Entonces, vemos esa situación. Y vemos que en la gran mayoría de los casos no hubo una evaluación de esos factores, el análisis de los factores de exposición a la rabia. Entonces, estos fueron lo que ocurrió con respecto a la atención de estos pacientes. Con respecto a la comunidad indígena de los Tucano Occidental, esta es una comunidad que dentro de sus creencias, una vez que el murciélago muere, su espíritu se encarna en la palma de carrizo. La caña es utilizada para la elaboración de instrumentos musicales y para poder elaborar los instrumentos musicales tienen que pedirle permiso al Consejo de Ancianos. El Consejo de Ancianos pide permiso a la Madre Tierra y de esta manera elaboran sus instrumentos musicales. Hubo una violación al pacto con la Madre Tierra y el espíritu del murciélago se enojó, empezó a atacar las comunidades. Dentro de su concepción, ellos tienen un poporo, una vasija ancestral. El que tenga este poporo tiene la protección. Esa es la concepción que tienen ellos. Entonces, muy respetable escuchar ese concepto y empezar a abordar la problemática y empezar nosotros a ver cómo abordamos dentro del componente de educación, hacer esa transposición de didáctica, la llaman los educadores, para utilizar esos elementos encriptados, ocultos en una cultura, hacer la transformación en un lenguaje sencillo que ellos puedan interpretar y conocer la prevención, el riesgo sobre la enfermedad. Aquí me encuentro capacitando con un video del Centro de Zoonosis de Sao Paulo y miren el interés de los niños alrededor de una presentación de dibujos animados sobre la prevención de la rabia. El trabajo interdisciplinario, aquí mi doctor Arias del Instituto Colombiano Agropecuario, una técnica ambiental, representantes de la comunidad, el enfermero traductor de nuestro trabajo. Y Piedrañí, según la mitología, sitio donde se originó el mundo para las comunidades tucano occidental en el Baupés. La discusión, pues, a raíz de lo que se venía presentando en nuestro país, era muy importante hacer una actualización con respecto a lo que venía ocurriendo con la atención de los pacientes. Aunque se había difundido en todo el país el protocolo de vigilancia de la rabia, la guía práctica para la atención de personas agredidas por animales potencialmente transmisores de rabia, no hubo una relación acorde con la aplicación de esta guía con respecto a la definición de exposición a rabia en las instituciones involucradas para la atención de los casos. Y como recomendaciones, pues aplicar el protocolo de Milwaukee cuando éste sea pertinente, cumpliendo los criterios y procedimientos del CDC Atlanta. Se requiere una constante actualización de la guía de manejo. En Santander de Quilichao, los gatos no fueron considerados un actor importante en la transmisión de rabia. La guía estaba desactualizada. Esto fue una evidencia que se presentó en la Redipra del año 2008 en Antigua Guatemala y se necesita actualizar la guía de manejo. Y es necesario promover la capacitación y actualización del conocimiento del riesgo en nuestras comunidades indígenas, campesinas afectadas por agresiones con animales domésticos y salvajes, así como la actualización en el abordaje del protocolo y de las guías de manejo en nuestro personal de salud. Eso era lo que tenía que contarles para el día de hoy. Muchas gracias.
Muchas gracias, doctor. Le voy a dar entonces la palabra al doctor Alan Jack, que va a continuar presentando.
Okay, we will move on. Our next speaker is Dr. Eric So from Cinnamore Biologics, and entitled, his presentation is Development of SYN-023 Anti-Rabies Monoclonal Antibody Cocktail.
Exactly, the red one.
Yeah.
This red point is the pointer.
Good. Okay, great.
Buenos dias. Good morning, ladies and gentlemen. It's my honor to participate in the Rita Conference again. Yesterday, there was a question, what PEP, post-exposure prophylaxis, is all about. In the simplest way, for category 3 patients, the PEP consists of 3 components: the wound washing, the vaccination, the vaccine regimen, and the third component is passive immunization, which is the infiltration injection of human rabies immunoglobulin or equine, ERIC, into the wound site. This product, SYN-023, I've seen my presentation in the past few years. It has been developed to address this unmet medical need. In this presentation, I'm going to share with you some recent analysis of this product. Anti-rabies monoclonal cocktail, 023 consists of 2 maps with non-overlapping epitopes. We've demonstrated in 3 animal models effective PEP, mouse, serum hamster, and beagle dog. And we've conducted 6 clinical trials to demonstrate the safety and efficacy of the product. It is designated as orphan drug by the US FDA. I mentioned the third component of PEP, the passive immunization. According to WHO's data, over 95% PEP performed around the world actually do not have the passive immunization due to the availability of HRIG or ERIC. And with monoclonal antibodies, we can easily scale up the manufacturing, robust product supply, and the manufacturing costs will be much less than the human plasma product. And monoclonal antibody does not carry risk transmitting bloodborne pathogens. But monoclonal antibodies do have a disadvantage, a weakness, which is potentially narrower spectrum of neutralization. It's the binding is so exquisite, it's zeroing into that binding site. So you may suffer the issue with spectrum of neutralization. And that's why WHO strongly recommend the use of cocktail, at least 2 monoclonal to address this challenge. And in US FDA's guidance document, the title is actually anti-rabies monoclonal cocktail, at least 2 monoclonals. For our 2 monoclonal, 011 and 012, here the diagram shows the rabies glycoprotein on the surface of rabies virus from position 1 to 524. The first one, CTB011, is a target linear epitope in the region of antigenic site 3. Antigenic site 3 is critical for virus fusion and internalization into the cells. So it's very effective at targeting against that site. CTB012 is very different. It doesn't have a well-defined binding site. It clusters here over near antigenic site 4 or a region called G5, but actually covered from 21 to 352. It's a conformational epitope, that's the term for it. Here's a diagram showing 021, 022. The orange colors 022, 012, and the red 011. Rabies glycoprotein on the surface virus form trimers, and the diagram show where the position of the binding residues. And it's clear that they are non-overlapping. In the past few years, we have worked with leading laboratories in the US, Canada, and China to test whatever rabies virus we can find, see whether or not neutralization activity can be demonstrated. Today, we've done 67, and it covers everything from dogs, fox, skunk, and all the way to bats, and show demonstrated neutralization. But we'd like to learn more about neutralization, even though you showed neutralization, but the neutralization activity could range 1,000-fold, 3 log differences. Now, what is the reason for it? How do we predict if we given a RNA rabies virus RNA sequence? Can we predict the binding, the neutralization? The first step to do that is perform an analysis. The critical residue determined by alanine screening mutagenesis, where I show for 01102 where the binding residues are. And the alanine scanning results confirmed by escape mutant study and also pseudovirus study to know for sure those are the critical binding residues. Then went into the GenBank filter for rabies virus using the keyword lyssavirus rabies, and we got 6,173 sequences. And we placed these sequences against 011, 012, these 2 monoclonal, and studied by country, host species, and phylogeny. This is just one example showing the lab standard strain CVS11 against some of the Lacirus bat viruses. Phylogenetically, they are distinct from CVS11. And from, in the chart here, you see here's position 1 all the way to position 524. And those highlighted the lines in blues are the amino acid with frequent mutations. And you see the inverted triangle on the top here is CTB012 binding residues. And on the bottom here in purple, so 011 residues. As you can see here, the binding residue actually are away from the most frequently you see variants, amino acid variant sites. And the analysis show that if we divided the result into country and host species and phylogeny, 011 highly conserved among isolate in China. But for North American, because there are more bats related viruses, 80 to 100% identity. And it's diverse at position of 355. The lower neutralization activity doesn't mean it's not neutralized. What we found is in the study, if we increase the concentration of neutralization, we can usually overcome the neutralization problem. Okay. Host species, highly conserved in dogs and foxes. Diverse in bats, position 352 or 389. These are antigenic site 3. Phylogeny, highly conserved in Arctic, Asian, cosmopolitan, raccoon, skunks, clades, and diverse at position similarly, okay? And diverse in bat similar positions. The other monoclonal CTP012, which I presented earlier, is very scattered, discontinued conformational epitope. It actually showed much better, higher conserved across 97 countries. The 3 countries that submitted most rabies virus are the US, China, and Canada. Host species highly conserved across 48 host species, and the phylogeny conserved across 55 clades. So these are the 2 monoclonal. It's interesting combination, and we realize how it worked much later from the point we selected the combination. we know for sure they are non-overlapping, and they are actually complementary in functions. Okay. When we measure the specific neutralizing activity using Susan presented CVS11 assay, the 011 has very high neutralizing activity. We screen thousands of monoclonal against rabies glycoprotein. 1,800 IU per mg, this among the highest neutralizing activity. The other one, 012, is lower neutralizing activity, but we know it offers better, broader neutralization spectrum. So the combination of these two monoclonal actually offer high neutralizing activity and also broad spectrum. The last point, the dose for our PEP, passive immunization, is 0.3 mg per kg, milligrams, much more accurate dosage compared to standard HRIG 20 IU per kilogram. And if we convert milligram to IU, we actually offer 25 times of IU per kilogram compared to the standard HRIG. In a way, we try to anticipate and compensate for the narrower spectrum inherently offered by monoclonal antibodies. This way, we not only can neutralize the virus we tested, but viruses we don't even know today. Getting to the clinical programs, since 2015, we've done 6 studies. The first one, first in human, PK/PD safety. The second one here is a PK/PD safety to compare sub-Q versus IM injection, because the bite site could be IM or sub-Q. Then we conducted a phase 2 study to examine the impact of monoclonal antibody on the vaccine immunogenicity. Concurrently, in China, we done a bridging study to confirm the PK/PD profile is the same in Chinese population and get ready for 2 pivotal trials. A phase 2B in US and the Philippines, 448 patients that we do head-to-head comparison with HRIG, blinded, double-blinded study to look at the safety and efficacy. And a phase 3 study with 1,000 patients in China, again, category 3 patient, 3-to-1 randomization, monoclonal 023 against HRIG. We are planning a phase 3B study, which is a pediatric study after the, hopefully, approval of the product. I mentioned the first pivotal study is US, Philippines, 448 patients, 1-to-1 randomization. And the second one is a larger study in China, 1,000 category 3 patients, randomized 3-to-1. The reason we came up with these numbers, in FDA's guideline, the agency asked for at least 750 category 3 rabies patients treated with the monoclonal. So the combination of these 2 pivotal studies, we have 985 patients, rabies patients with monoclonal. The 2 studies at the same primary endpoints. The first one is a superiority endpoint. The 023 plus vaccine compared to HRIG, on day 8, it offers higher neutralizing antibody. The second one is protection. We follow the patient for 365 days and make sure nobody developed rabies. And both primary endpoints were met. Here's a diagram of geometric mean concentration of RVNA, y-axis. The red line is the seroconversion, or 0.5 IU per mil, adequate for protection titer. The red curve you see here, HRIG, it takes all the way to about day 15 after vaccination, you reach a very high level. But with monoclonal antibody, because we gave the patient higher dose at 0.3 mg per kg, so the day after the administration of the product, the titer already way beyond 0.5. So the area under between these 2 curves represent a higher neutralization power offered by monoclonal. And this is a different presentation percentage subject with RVNA greater than 0.5. The blue lines, monoclonal 023, the rest H-rig. You see it with monoclonal, it shut up right away. The FDA asked us to do a comprehensive integrated summary of safety, ISS, across 6 clinical trials. And we spent about 5 months doing that. And the results are not very surprising. 023 is very safe, as safe as H-rig, but a few highlights I'd like to point out here. One is any solicited treatment emergent adverse event, 023 is less than H-rig. Treatment-related TAEs is less. Okay. Specifically, it's the injection site swelling and pain, much less in monoclonal compared to H-rig. Also, less headache. The summary from all these clinical trials, we show that the product is safe and well tolerated, and it offers less site of injection swelling and pain compared to H-rig. The primary reason is a highly purified product. The viscosity is only about 20% of H-rig. And the efficacy show that H-rig, compared to H-rig, day 15, much higher RVNA, and the comparable percentage subject greater than 0.5 to 99 days. Protection 365 days. Currently, we are under the China CD review of BLA. Hopefully, it will be done in the next 2 months. And US BLA in the fourth quarter, in about 2 months, we'll submit the BLA. Lastly, I'd like to acknowledge our collaborators for all the neutralization studies, KSU and the Canadian Center of Expertise Rabies, Susan and Christine are here, Pox and Rabies, Brent, CDC, some of the CDC colleagues here, and the 2 leading China rabies lab. Thank you.
Unfortunately, there's no time for questions, so we need to move on. The next
Okay.
speaker
Great, thank
is
you.
Dr. Gerlyn Sponseller from Boehringer Ingelheim, and her presentation's entitled Rabies and Dog Bite Prevention Training in Southwestern Kenya.
No, yo no quiero. I don't know why it's not working.
Buenos dias. Good morning. I'm Geraldine Sponseller from Boehringer Ingelheim, and I am a veterinarian. I'm very pleased to speak with you for a few minutes this morning about a rabies and dog bite education initiative that we have instituted in Kenya. Just as a quick review, both Colombia and Kenya are equatorial nations, so they are both countries straddling the equator. But I believe that today in Bogota, we are at a much higher elevation, a much higher altitude than where we are working in southwestern Kenya. We have focused our initiative in Narok and Bomet counties on the western border of Kenya with Tanzania, and that is the Masai Mara. For those of you who follow Kenyan wildlife, you may recognize that as one of the most famous places in the world to view wildlife. And for that reason, if you look at the map on the right, there are also lots of protected areas in Narok County, specifically related to wildlife conservation. In addition to wildlife, however, the Maasai people live in Narok County. They have raised cattle and sheep and goats for thousands of years in that same area. And so dogs play an extremely crucial part in life in this area because dogs are found at the interface between wildlife and civilization, where the Maasai are trying to preserve their livelihoods, which are the cattle and the sheep and the goats. So where we have dogs that are unvaccinated, you can appreciate that we will also have cases of rabies, and unfortunately, that includes cases of human rabies. I believe that rabies probably shares difficulties in surveillance with all other neglected diseases, and so it's difficult to know exactly how many cases of human rabies are in Kenya, but it's likely hundreds of human victims every year. And of course, Kenya has identified rabies as a zoonotic disease priority. Kenya has a plan for the elimination of human rabies, and this plan is in line with the global goal of 0 by 30, and the plan includes promoting responsible dog ownership, which includes rabies vaccination, and also increasing awareness about rabies and about preventing and managing dog bites. So the Beringer-Ingelheim Stop Rabies Initiative, of course, provides vaccinations for dogs, but we also recognize that vaccination against rabies is not the complete solution to the problem, and so we are also supporting both educational and surveillance initiatives. So we have begun our educational initiatives with children because, of course, we know that a very large number of rabies victims are in fact children. And this only makes sense because children are lower in stature, they're close to the ground, and they like to play with dogs. So we're focusing our efforts with training children. And we're employing a booklet that is available freely from the Global Alliance for Rabies Control. You can find this booklet free on their website. It's available in numerous languages, and it covers the topics of responsible dog ownership and also explaining dog behavior and therefore how to prevent dog bites and ultimately rabies. So we speak to children about 5 freedoms associated with owning pets. And of course, we talk about food and water and shelter and providing veterinary care and vaccination against rabies when possible. We also take the opportunity to speak with children and teach them about empathy and seed the idea that dogs and people are sharing the same space. We are all sharing the same planet, and so when we contribute to animal health, we're also contributing to our own health and the health of the planet we share. And by teaching children that dogs are fellow creatures, we are also then able to help them appreciate dog behavior. And if they can appreciate the behavior of dogs, they begin to understand that just like people, there are mean dogs, there are nice dogs, there are friendly dogs, there are aggressive dogs. And so if children can understand that dogs behave in different ways, then they also have the opportunity to change their own behavior based on how they see a dog acting. And so this is very helpful because they are actually then able to avoid potentially dangerous situations. They can avoid being bitten, and ultimately this can be a life-saving measure if they're able to avoid being bitten by a rabid dog. And I believe that it would translate into numerous languages that a very small amount of prevention is worth a very large amount of cure. And so ultimately, we feel that by targeting children, explaining to them about dogs, about behavior, and how they can interact safely with dogs, we can actually prevent a lot of dog bites and potentially also prevent cases of rabies. However, we do live in the real world, and so we understand that dog bites do happen, and so it's equally important that children understand what to do in case of a dog bite, that they understand the importance of wound cleansing for 15 minutes with soap and water, and that they understand that a dog bite is not a cause for a secret, that they need to tell an adult, and specifically they need to tell a responsible adult so that the child can receive appropriate medical attention and potentially post-exposure prophylaxis if necessary. So what does this look like in Kenya? We have a veterinarian and we have a veterinary technician, and they provide individual presentations to schools in Naric and Bomet counties. And they target primary school children being the audience that is most agreeable to this message. We've been going for 8 months now, and so we have reached over 30,000 children, and this has been done by presenting almost 300 times in almost 150 schools. We're able to record our data, again, with cooperation from the Global Alliance for Rabies Control. They have a free rabies surveillance app that can be used with laptops and with Android phones. And so we're able to record the initiatives, both the GPS coordinates and also how many children were reached, and an assortment of details that you can tailor depending on what data you would like to include. The app isn't just about education. It can also track dog vaccinations and dog bites. And so we are trying to incorporate a little bit of active surveillance by also asking children simply, have they been bitten by a dog? So when children are receiving the training, we're also trying to collect surveillance data at the same time, and we're able to enter all of that data into the same application, so that hopefully we are creating a bigger picture of what's going on with rabies in Naric County. So we've made some progress, but I'm sure you can appreciate that we also have some challenges. There are 500,000 children, primary school age children in Naric and Bomet counties. And so with the average school size being about 300 children, you can appreciate that that is a lot of presentations. In addition, we are limited by resources. There are very few computers available in schools in Kenya, and certainly Naric and Bomet counties are no exception, and there is even less access to internet. So we are limited to using pencil and paper to deliver our rabies and dog bite prevention message. And of course, this comes with its own challenges in terms of printing and transportation. So we have a lot of schools, we have a lot of children, and we don't have a lot of resources. However, what we do have is advocacy, and we do have some proponents of One Health. So we have been very lucky to engage with county officials in both counties, both veterinary officials and both representatives from human health care, and they have been very helpful in identifying community health volunteers so that we are now able to provide the program to a much larger audience. And what this means is we are employing a train-the-trainer approach. So instead of having one veterinarian who individually might be able to visit 10 schools, instead, if we can train an entire classroom of adult volunteers, and then each of them can visit 10 schools, then we are reaching children in 100 schools in the amount of time that we started only reaching 10 schools. So we're hoping to expand exponentially as we move this program forward. We're depending on our volunteers, and we are also depending on the children themselves, because the average household size in Kenya is 5 members. And so if you say that we have reached 30,000 children in school, we're hoping that the booklets that we're providing and the information that we're providing to them about rabies and preventing dog bites, they will take that information home, tell their families what they learned at school, and our reach will expand exponentially. So if you're interested in this initiative, I'd be happy to answer questions. And thank you very much for your time.
We have 4 minutes for questions. We need a microphone at the front, at the front, at the front. I don't know if that's translated.
This is a wonderful experience, and just one small thing I would like to know is, what do you think would be done in terms of sustainability of such kind of approaches, which is very important, but sometimes, you know, in the long term, it's different when you are not there. And I would like to know, what are you thinking about the tools to make this sustainable in time?
That's an excellent question. Thank you very much. And I do not have the exact answer to that. So if you do, I would be very interested because we talk a lot about sustainability.
Well, you sent me back the question, but my question would be in connection to that, the importance to approach to local health authorities to try to empower these health authorities to pursuing, to keep doing this and trying to make this sustainable, as given the importance.
No, I wasn't intending to avoid your question. Definitely, we talk a lot about sustainability, and it's an ongoing conversation. And in particular, that's why we've chosen to work with local Kenyan veterinarians and technicians so that they feel empowered to be working in the communities where they are living. And they are also then able to make those connections with county officials at both the veterinary and the human health side. And we're hoping that by showcasing Narok and Bomet counties and our continued success in this area, that we might be able to expand to other counties and also achieve the attention of the Ministry of Education.
Dr. Willoughby?
I'd like to suggest that may not be the best question. One of the problems is that many times we go for perfection, and often good is better than the perfect because it can be attained. So if they educate children to not get bitten as frequently, and there will then be fewer cases, and the effectiveness of that program is much more impressive and will sustain a lot better than choosing a high bar which can never be reached. The concept is that of Mother Teresa, Catholic saint, one person at a time. And by doing that, you do much better than worrying about sustainability of a program that appears to be very successful. If the metric of that program with the mapping is such that rabies cases drop by 50%, that'll be obvious to everybody, and it will sustain without having to program the sustainability.
Any comment?
Thank you for your comment.
Okay, thank you very much, and we'll move on.
Bueno, vamos entonces a continuar con la presentación de la doctora Alma Aguilera de los Servicios de Salud Pública de la Ciudad de México. Muchas gracias, doctora, y bienvenida.
Señalar, pero para pasar.
Les recordamos, por favor, que si tienen alguna pregunta, la escriban en el papel y nos la hagan llegar hasta el escenario. Muchas gracias.
Sí, de hecho, nos llegó una pregunta del ICA para el doctor Eric Zhao. Entonces voy a entregar la pregunta y en el coffee break pueden hablar.
Hola, buenos días. Agradezco al comité por seleccionar mi trabajo. Este trabajo es sobre capacitaciones a médicos y enfermeras en servicio social. Yo soy veterinaria. Este trabajo se realizó en México, en su capital, en la jurisdicción sanitaria Iztacalco. Bueno, el servicio social en nuestro país se implementó en el año de 1936 con la función de servir al hombre del pueblo. Esto significa a las zonas rurales donde no hay acceso a servicios de salud. Además, para que nuestros médicos adquieran el conocimiento y experiencia para realizar un buen trabajo en su vida profesional. Aunque México fue declarado como un país libre de rabia transmitida por perro, es importante decirle a estos médicos que ante la mordedura de un perro se debe de realizar la vigilancia epidemiológica y se debe de aplicar esquemas de vacunación de ser necesario, además de que ellos ubiquen que hay otros animales que infectan de rabia. Nuestra línea de capacitación, bueno, nuestra propuesta de capacitación va en 2 líneas. Una para los médicos de servicio social que están a punto de titularse. En ellos hablamos sobre la normatividad, sobre la rabia humana y la rabia animal y les ponemos ejemplos clínicos de diferentes agresiones de diferentes animales para que ellos los resuelvan. Mientras que en los estudiantes que son de segundo y tercer año, les explicamos la enfermedad en general, les explicamos un poco de la normatividad y les explicamos sobre que hay expertos de rabia a los cuales pueden unirse o nos pueden preguntar si ellos tuvieran dudas. Yo ingresé al centro de salud en el año de 2019 al servicio de epidemiología. Aquí me di cuenta que a los médicos de servicio social no se les capacita en cuestión de rabia y que vienen con deficiencias de este tema desde la universidad, por lo cual se decidió empezar a capacitarlos. A los médicos se les capacita 1 a 1 personalmente. Logramos capacitar a 17 médicos y a 51 enfermeras, pero ellas es con capacitaciones grupales. Cabe aclarar que para que nuestra capacitación sea aprobada, el promedio mínimo es de 8. En el primer examen, en la fase inicial de los médicos, el 100% reprobó el examen. Después de la capacitación, el 82% aprobó, pero el 18% reprobaron. ¿Qué hacemos con ellos? Nos vamos a una segunda fase de capacitación. En cuestión de las enfermeras, el 100% reprobaron el primer examen, el 64% aprobaron el examen final y el 35% reprobaron nuevamente el examen final. Bueno, aquí se ve la evidencia de que capacitamos en nuestras oficinas a los médicos 1 a 1 y a enfermería son capacitaciones grupales. Enfermería representa el 75% y medicina representa al 25%. También logramos capacitar a médicos y enfermeras estudiantes de segundo y tercer año. Fueron 111 médicos, con ellos se movió un poco la estructura porque en el primer examen el 100% reprobó, nos fuimos a el examen final donde 61 alumnos pasaron y 50 reprobaron. Nos fuimos a una segunda fase de capacitación, 40 de ellos aprobaron, 10 nos reprobaron. Iniciamos una tercera fase de capacitación, pero en ellos ya les pedimos que ellos nos dieran a nosotros la capacitación, que ellos estudiaran la normativa y estudiaran qué es rabia y nos capacitaran y fue la única forma en que logramos que ellos 10 nos pasaran el examen. En cuanto a enfermería, 60 reprobaron el primer examen y en el examen final el 75% nos pasó y el 25% nos reprobó. Igual van a segunda fase. Bueno, este es un video donde capacitamos a estos chicos en las aulas. Tenemos que hacer gestiones para que sus jefes nos presten a los chicos porque como son la mano de obra de las instituciones, pues hay que jalar y destinar tiempo para ellos. El 35% es enfermería y el 65% es medicina. Hace un año me dijeron unas palabras, alertar a los médicos sobre la zoonosis salvavidas, así es que continúe con su valioso trabajo, lo que me inspiró a ir más allá de mi unidad. No me quedo aquí y por lo cual en el año del 2023 gestiono con mis autoridades jurisdiccionales para llevar esta capacitación a toda la jurisdicción y ellos la aprueban. Con la anuencia de la doctora Verónica Gutiérrez y el apoyo del doctor Luis Lecuona, realizamos la primera capacitación masiva de la jurisdicción, esto a cargo del servicio de epidemiología. Llamamos a 78 médicos y enfermeras de servicio social a través de comunicados, a través de memorándums, a través de correos. Solamente asistieron el 18 estudiantes de enfermería. ¿Esto por qué? Sus autoridades no consideraron importante ser capacitados de rabia. Prefirieron que ellos continuaran en sus actividades laborales. De estas 18 enfermeras, el 100% reprobaron su primer examen y su examen segundo, después de la capacitación, el 55% aprobó y el 44% reprobaron. Aquí ocurrió algo interesante porque a nuestro llamado se unieron 6 médicos. 3 médicos de ellos ya están como médicos adscritos, ellos ya atienden a pacientes agredidos por animal y el más bajo nos obtuvo una evaluación inicial de 1.6 sobre 10 y en el examen final nos obtuvo 5.8. Son los médicos que están atendiendo a nuestros pacientes. También acudieron 3 epidemiólogos, uno de ellos en nuestra evaluación inicial obtuvo 5 y ya se fueron sobre 9.2 y los demás sobre 10. Igualmente, ellos supervisan a los médicos de consultorio, o sea, ellos deben de tener más bases todavía que estos médicos. En agosto del 2023, nuevamente con la anuencia de la doctora Verónica Gutiérrez y el apoyo del doctor Antonio Chávez del Senaprese, realizamos la segunda gran capacitación para la nueva generación de médicos que ingresaban a nuestra jurisdicción. Esta vez cambiamos la estrategia, pedimos el apoyo de enseñanza. Enseñanza tiene la facultad de solicitar a los estudiantes y de que no les puedan negar el permiso sus autoridades. Aquí acudió el 100% de los estudiantes, capacitamos a 22 médicos. Nuestra evaluación inicial, el promedio más alto fue 6.2 sobre 10 y el más bajo fue 2.6 sobre 10. En nuestra evaluación final, 6 de ellos ya lograron el 10, 2 de ellos todavía obtuvieron un menor de 8. Recuerden que para que nosotros la consideremos como aprobada, tienen que superar el 8. Significa que 20 ya nos aprobaron y solamente 2 nos reprobaron. Enfermería, capacitamos a 117 enfermeras, de las cuales 109 obtuvieron una calificación menor de 4 sobre 10. En la evaluación final, ya solamente 25 se fueron a una evaluación menor a 8 y 4 de ellas ya lograron el 10. Nuestros resultados. Logramos capacitar en el Centro de Salud Mazzotti a 17 médicos, 51 enfermeras, esto a través de 12 capacitaciones personales cara a cara y 4 grupales. En la jurisdicción sanitaria Iztacalco, a través de 2 capacitaciones masivas, logramos capacitar a 22 médicos, a 135 enfermeras y de los estudiantes en el Centro de Salud Mazzotti, a través de 11 capacitaciones grupales, capacitamos a 111 médicos y a 60 enfermeras. Esto nos da un total de 150 de médicos y 246 de enfermería. Aquí hay un nicho de oportunidad, porque regularmente capacitamos a los médicos, porque ellos son los que llevan el esquema de vacunación más la atención, pero siempre debemos de recordar que trabajan médico y enfermera a la par. Entonces, si nosotros capacitamos a enfermería, ellos pueden dar un foco rojo al médico que no sepa. Entonces, debemos de apostar también para enfermería. Posterior a nuestras capacitaciones, ya fuera de primera, segunda o tercera fase, nuestro promedio final fue de 8.7 sobre 10. De las preguntas que hicimos, que fue nuestra medida para evaluar, fueron 20. Los errores que más hubo fue que no saben resolver casos clínicos. Ellos piensan que los roedores transmiten la rabia. Ellos no saben que los vampiros, bueno, los murciélagos, transmiten la rabia. No saben los esquemas de vacunación, no saben que los animales silvestres, al hacer una agresión, el paciente necesita aplicación de vacuna, no saben tampoco que aplicando la vacuna en tiempo y en forma previene la muerte, no saben que un perro después de una mordedura necesita ser vigilado por 10 días. Y en nuestro examen final, las preguntas que continuaron con más errores fue la resolución de los casos clínicos. Solamente el 48% ya supo resolver casos clínicos, el 52% todavía no. No saben los esquemas de vacunación, el 63% ya lo supo aplicar, pero el 37% no. Esto es porque no saben conjuntar las variables de lo que implica una mordedura. Nuestras conclusiones. Con las capacitaciones implementadas, se pudo contribuir en profundizar el conocimiento de rabia y con ello mejorar el manejo y atención del paciente expuesto al virus de la rabia, para con ello evitar muertes por falta de competencias clínicas profesionales en la atención. También les explicamos lo que es Rita y que hay un grupo de expertos trabajando en rabia. Bueno, aquí como testimonio de los médicos que pasaron por el programa de entrenamiento, recibimos buenos retornos. Ellos nos dicen que la capacitación les significó una mejora en su vida profesional. Ella no entendía muy bien sobre los esquemas y qué pacientes necesitaban sí o sí el tratamiento. Este doctor no sabía que la rabia era mortal y que había prevención. Bueno, para combatir el vacío de conocimiento de la rabia, el SENAPRESE lanzó el curso virtual para capacitar a todo el personal de salud en México. Este curso tiene como la fortaleza que hay un mapa de la República Mexicana. En este mapa, todas las personas que son capacitadas aquí se van marcando en ese mapa. Entonces, ellos pueden saber dónde hay gente que sabe o no sabe sobre rabia y con eso hacer otras acciones. Bueno, por un México, no se escucha, pero decimos, por un México sin rabia humana, capacitemos a nuestro personal. Es por lo que vamos a apostar ahorita. Y pues estoy aquí en representación, pero somos muchos trabajando aquí. Este trabajo tiene el apoyo de muchas manos, aquí vienen cada uno de ellos. Agradezco a mi familia y a ustedes por su atención.
Muchas